Hi, everyone. Welcome to this afternoon's agent-based modeling talk. We're very happy to have Dr. Victoria Ng here. Dr. Ng is an infectious disease epidemiologist and a senior scientist at the Public Health Agency of Canada. Her expertise is in quantitative risk assessment, disease prioritization, infectious disease epidemiology, and statistical and mathematical modeling of infectious diseases. She's been very busy during COVID-19, working on COVID-19, but also busy before that, working on two areas of public health, modeling the importation and transmission of exotic mosquito-borne diseases into Canada under current and projected climate change, and also in incorporating machine learning techniques into public health research and practice. So since February 2020, her focus has been, of course, on responding to the COVID-19 pandemic, including developing an agent-based model to explore the effectiveness of non-pharmaceutical interventions and vaccination on COVID-19 transmission in Canada. And her work is previously in the area of infectious disease epidemiology and modeling for the Hospital for Sick Children, the University of Guelph, and Public Health Ontario. And we're really happy to have Dr. Ng here. We've had lots of connections over the past couple of years, talking during meetings about COVID-19 research, looking at agent-based models versus deterministic models, incorporating different aspects of multi-level infection into populations. And it'll be great to hear more about what Dr. Ng has to say today. Thank you very much for coming.
Great. Thank you so much for that kind introduction, Jane. And thank you also to the committee for allowing me to present some of the work that we've been doing at the Public Health Agency of Canada. So as Jane had alluded to, my team at the Public Health Agency of Canada has been doing a lot of work in responding to the COVID-19 pandemic. And so it's always a great opportunity to be able to sort of pause a bit on the modelling side of things and present our work and have an engaging discussion with people about the work and our findings. So thank you for today. And my presentation today will focus on one of many models that we've developed at the agency, but particularly given the theme of the series, it will be on agent-based modelling for public health. I've titled it, Is It Worth the Effort? And what have we learned over the last 2 years? I hadn't really thought too much about those questions in the title when I gave Ali the presentation title about 2 weeks ago, but I think I will be able to present quite a bit about what we've learned over the last 2 years, and I'll dabble a little bit with, was it worth the effort? So it is quite a big talk today. I will probably talk faster than usual, but I do list sources of information throughout my deck. And everything that I'm discussing is publicly available. So if anyone wants to go back and sort of look at this talk and look at the sources, the links, then you're welcome to do that. Everything is available online. So I'm going to begin. So this is my presentation outline. I'll be giving a quick overview of models used by the Public Health Agency of Canada during the pandemic response. Then I'll really focus more on the technical aspects of the FAC agent-based model, which I developed at the agency. It is something that I know this audience would be particularly interested in, so I'll try to give a bit of highlight on the technical aspects. But then I wanted to focus on the two questions in the title. So what have we learned over the last 2 years, especially through the ABM modelling and over the course of the pandemic in Canada? And also lessons learned. How was the model used at each point in time of the epidemic, and how is it used at that point in time to inform public guidance? Then I'll really talk a little bit about, is it worth it? So I've kind of switched the title a little bit. As I put together this deck, I realized it made more sense to go through it this way. So lessons learned first, and then was it worth the effort? So just a quick overview of some of the models that we've developed at FAC. They can be broadly categorized into three main categories. So first we have the statistical forecast models. These are short range forecasts of expected cases given recent incidents. Usually they project about 1 to 2 weeks in advance. Then we've got the long range forecast models. These are more dynamic compartmental models adapted to project near future, so about 1 to 2 months in advance, given recent incidents. And these are sort of models that we use to explore scenarios, particularly for control, releasing control measures, variants of concerns, and vaccination. Then the third large group of models that we have are the dynamic models. I actually say large, we don't really have many of them. It's just they're more complex models, and we do have a deterministic age-structured compartmental model. And the one that I've been working with over the last few years is the agent-based age-structured computational model. Initially, both of these dynamic models were developed to model public health control measures, but they've been adapted over time. I guess no one expected the pandemic to last for 2 years and ongoing. And so over time, they've been adapted to model, in addition to public health measures, the effects of vaccination rollout, variants that have emerged across Canada, boosters as they were available, and waning immunity. So this first slide of the agent-based model is just an overview. I will go into details of sort of certain aspects of the model over the next few slides. But briefly, the FAC agent-based model is a stochastic model. It's a mathematical model of SARS-CoV-2 transmission in Canada. It is representative of the Canadian population. We do model per 100,000 given the computational limitations that we have with an agent-based model, but it is representative of the Canadian population in terms of demographics, behaviour, and where possible, we try to parameterize a model with data from Canada. It is age stratified with 10 age groups, and it's similar to an SEIRSV compartmental model to account for waning immunity and vaccination, which have become available. But instead, we model individual health states. So instead of these large compartments, each individual have their health states modeled as these separate compartments. And I'll go into a bit more detail over the next slides about these health states, but the figure on the right shows each of the individual health states that each person in the model is modeled. It is a code-based model, so I don't have any pretty graphics except for this one that I'm presenting and sharing. Initially, we did develop it with graphics because it does have locations or different locations in the models, and we did have agents moving back and forth, and it was pretty cool to see them move around and the health states change colors. But we realized computationally it was really expensive to have a model that had graphics. And so we've moved to a code-based model, absolutely no graphics. It's quite boring. The outputs are about 1,000+ .cvs output files per simulation or per model scenario run. But it grabs all the most important information that we're interested in, and we can sort of manipulate those outputs. Despite not seeing what's happening with the model when it's running, we do have all those outputs to be able to plot and analyze results from. It is a daily time step starting from February 2020, although there's been some internal talks that, with 2 years into a pandemic, we may need to start shifting into having a preset time period and cutting out the 2 years history of the pandemic. That's work in progress right now. It is a large model. It includes over 200 parameters, and these include demographic, behavioural, epidemiological, public health interventions, vaccine rollout and coverage, waning immunity, emerging variants as we see them emerge in Canada. So quite a comprehensive model. And this is just some more simplistic flowcharts. I've taken that figure in the previous slide and sort of made it a little more plain. And it is very similar to, a lot of people would recognize this, to a SEIRSV model, where you have agents, the majority of agents will start out as susceptible, except for the first few that we enter into the population as infectious to be able to start the outbreak. And agents generally will stay insusceptible until they become exposed to an infectious agent, and then they themselves will follow this health state chart where they will go into a period of a latent period, so before they have any symptoms and before they're infectious. We separate exposed because there's the sort of exposed to someone who was symptomatic, so we can trace you. This is one of the public health measures. And then the unexposed, or the U-exposed compartment for agents who have been exposed, but from someone who did not have any clinical symptoms and were symptomatic, and so contact tracing is not really a possible choice for those people. So we had initially separated out the exposed compartments for this reason, because we knew we were exploring public health measures, and you can't impose, or you can't contact trace people that don't know where they got their infections from, which actually mimics reality. And so we try to sort of build and structure this model the way that we do see COVID transmission occurring in reality, at least in Canada. And so after the latent period, agents will go into a pre-symptomatic infectious period, again, similar to what we do see. And part of the problem with COVID is that people are, I guess, infectious before they're symptomatic. So these 4 states in the red box are the states in which agents are infectious, and during these states of their health, in the model, they are able to infect or exposed and have contacts with other people and start spreading infection in the community. From the pre-symptomatic infectious period, you move into the symptomatic period. Here, agents continue to infect others, but they have clinical symptoms which may affect their behaviour, and we do have sort of different behaviours in the model as well. So during this period, people will infect according to, I guess, severity of the symptoms as well. And then they move on. If you're mild, there's a period where you're no longer infectious. We just capture you in the sort of second half of your mild symptomatic state, where you may be symptomatic, no longer infectious. Eventually you'll recover. If you are symptomatic, you will then have the chance to be predetermined as being hospitalized or going into ICU. And all of these probabilities, it's probability based on distributions that we have, I guess, extracted from Canadian data. And so in general, the older you are, the more chance you have of having these symptoms, and you will either recover if you're in hospital, or you can die. If you are assigned to be admitted to ICU, there is a pre-ICU period, followed by ICU period and a post-ICU period. And this is to be able to sort of capture the utilization of hospital beds more accurately, because when you're admitted to ICU, you don't necessarily go straight into an ICU bed with a ventilator. There is a couple of days before, and there's a recovery period where you're not really taking up the bed in the ICU. And then similarly to hospitalization in the ICU, you have the chance of recovering or dying. If you're a symptomatic case, which is what this box here, AI, is, then you don't go through any of these previous states. You just go straight into to a symptomatic recovered period. So you've got death here, symptomatic recovery, and asymptomatic recovery. And we actually have waning, so that's what these arrows lead to. Essentially, your probability of reinfection will increase depending on time from last infection, the SARS-CoV-2 strain that you're exposed to, and your vaccination status. So that brings me to the next slide, where I've added some new boxes now, and these contain the vaccination states, health states. In the model, we have dose 1, dose 2, dose 3, as we see in Canada. We are starting to think about dose 4 because that is currently available for Canadians. You can be selected to get dose 1, dose 2, or dose 3 in the states that I've outlined in green. So if you're susceptible, and then during your latent period, pre-symptomatic period, it's very rare. So in the model, just like in real life, it's very rare that you will go and get vaccinated during your latent period or your pre-symptomatic period, but it happens. And so we want to sort of implement the model in the way that we would see things occurring in reality. And obviously the doses will go in order. So dose 1, dose 2, dose 3, but there's any number of different ways to be vaccinated in the model. So you could be symptomatic when you get your, susceptible when you get your first dose, but then you have to clear your infection and be recovered before you get your second dose and then your third dose. Or you can be, get your first 2 doses while you're susceptible, but then you don't get your third dose until you're recovered if you happen to get infected during the time period between your first, second, and third dose. And so there are lots of different combinations of how you get to a vaccinated stage, and that is implemented by code through equations in the back of the model. And similarly for the vaccinated, there is waning immunity as well. So once you're fully vaccinated, we track the time that you received your third dose, and there's a probability of reinfection. I should say there's also probability of being infected while you're attaining your immunity from your first dose and from your second dose, and your probability of being infected or reinfected will decrease over time as you mount an immune response to the vaccine. And we track everything in the model, and that's why it's very computationally expensive, because we track, the day that you got infected, the day you got your first dose, second dose, your third dose, combination of those orders, and then sort of we apply your probability of infection based on that, but also based on the next variant that you're exposed to. So there's a lot of decisions happening behind the model, but it is all captured in the model to mimic what happens in real life. So this is the model environment. There is heterogeneous temporal and spatial mixing in the model. We have 4 main locations in the model. We model households, we model workplaces, schools, and these sort of other generic locations. These could be shopping malls, grocery stores, movies, theaters, galleries, places where we would expect mixing to occur between different age groups. So in schools, you would expect you're mixing with your peers, and so there's similar age mixing in that location. But in the other location, it's kind of like a capture for all other locations in the model. We could have gone a bit extra and added a few more locations, but I'll show you the contact matrices that we use in the next slide, and this is kind of why we just stuck with the 4 locations. And also, we wanted to keep things simple. It is quite a complicated model already, so there are some sort of compensation needed to be able to make the model run efficiently. We assign agents to these locations according to their demographic data. So looking at Statistics Canada, demography, based on your age group. We look at households, and we clump people in households according to how we see households are grouped together in Canada. And so as much as possible, we try to parameterize the model with Canadian data, obviously, because we're modeling for Canada. Movement is daily, and it will vary between weekdays and weekends, both in location and frequency. So, I guess this also mimics what we see in real life, right? Mondays to Fridays, most people have regular routines, but on the weekends, you kind of mix it up a bit. And so we do that in the model as well. We have a semi-open population. We don't account for births and deaths because I don't think anyone anticipated that we'll still be using this model 2 years down the track. But that's probably something that we'll have to think about and update shortly, because people are clearly aging in the population, and this will have an impact on some of the things that we're modelling. But it is a semi-open population because we do recognise the importance of imported cases, and we have return travellers, and we divide them up into return travellers who are permanent travellers that come back home and stay in the household, and then we have the transient travellers. So these could be truckers or essential workers that are infected, possibly infected, and they come in and out of the model environment for a few days at a time. And we get this data from the FAC importation risk model. So my colleagues who manages this model, every week they look at sort of, I guess, the testing and the number of travellers that are returning to Canada, and their model estimates the number of imported cases that they anticipate we have seen in that past week into Canada. And so we add that into the model, adjust it for the population size that we're modelling for, but we do sort of account for that. And it is very important, as you can see in this figure at the bottom here, this is Omicron. So, prior to Omicron, the number of imported cases were pretty much, around the same. There was a few more during the Delta wave, but Omicron really made a huge difference. And so we try to account for this. And also because you'll see in an upcoming slide, we also model I guess, border control measures as one of the public health interventions. So it was important to include imported cases into the model. So this is the contact matrices that we use inside the model. It's age-based contact structure. They're based on Canadian estimates from this Prem et al. Paper, 2017 paper. used by a lot of other Canadian modelers that we've had the pleasure of working with and collaborating with and picking the minds of. And so because their projections for Canada came in 4 different locations. So they do sort of contact mixing for the home, for workplaces, for school and other locations. That was kind of by design why we designed the model the way that we did. And essentially you can see with these contact matrices that people tend to have certain patterns when they're contacting or having contacts with each other. So in general, the diagonal line that you see, that indicates that most age groups are having the same kind of contacts with people of the same age group. You see this within the household. So for example, it could be, parents are having contacts with the same age groups as, parents are having more contacts with other parents than their kids, but they do have contacts with their kids as well, obviously. Kids are going to have more contacts with their siblings, if there are siblings. And we see this in school as well, especially in schools. Kids are cohorted in their grades, and so they're going to obviously have contacts with other kids of the same age, but you can see sometimes they have contacts with other people outside their age group, teachers, and then in the workplace, this is really interesting. You also have contacts with people within your same age group, but in a workplace, you're kind of forced to work with people outside your age group as well. So you do have to have those contacts too. This is really important though. The contact matrices for Canada is really what drives transmission in the model, because we don't actually, because we don't have movement in the model, our agents aren't going and having sort of physical contacts with each other. The way that we coded the model is that we have our infectious agents. So when you're one of each of these 4 health states, the pre-infectious period or the symptomatic infectious period, you're constantly searching for people to have contacts with and to infect them. And so infectious agents will have a hit list of people to make contacts with each day. And this list is divided into people in your household and people outside of your household. And each day, because each agent is assigned to a location, so we keep track who is supposed to be where, but they're not moving to that location. It's just that we have a list of who you are and where you're going to. And if you happen to be in contact with an infectious agent or be in a location where they can contact you, from that list, the agents will then have a probability of giving out their daily contacts to certain people in the locations that they've been assigned to. But it's not random. Some are random, but most of it's based on their age groups. And so the probability distribution is based on this contact matrices. So we really try to mimic, what contacts people are having in real life and putting that into the model. And behaviors will vary. Depending on the location. So whether it's a weekday or weekend, you may not be in contact with the same list of group of people. It's going to vary by age. Sometimes people are not available to be contacted because if there's a public health intervention, like a closure, then they're not available to be in that same location as you're normally assigned to. And then there's also compliance. So we try to model compliance to certain interventions. And if someone is compliant and you're not, then you don't have the opportunity to sort of be in contact with them for the day. So moving on to the next slide, these are public health interventions. We implement them at the individual, household or population levels. Non-pharmaceutical interventions, MPIs, are applied or triggered by different health states. So contact tracing and quarantine are applied in this latent period. And then we have case detection and isolation, which are applied in the sort of symptomatic period. So once you're symptomatic, you've been able to be detected as a case, we can isolate you and ask you to isolate from your household members as well. We have additional testing in the community, which can be applied to some of the other, like it is applied to other health states as well, because additional testing is indiscriminate. But particularly we're trying to target the pre-symptomatic states where we don't know that they're symptomatic, they don't know that they should be isolating from people, but if you test and you're actually, if you are infected, then that will maybe change your behavior and try to get you to isolate from others and not leave your household. We have physical distancing, which is reducing contacts in certain states for the agents that are out there actively seeking contacts to infect. We have community closures, which is a population level intervention. It's going to affect everyone, but we don't, you can apply these to a small group of people if you want. So you can apply them to just schools, or you can apply them to non-essential businesses. You can apply them to everyone, or just a proportion of, schools. So the model is quite adapted to flexibility. And then there's border measure controls. So, here we introduce imported cases, but if we want to model border control measures, we can sort of model that by reducing or increasing the number of imported cases as a result of these changes in border control measures. And that will then allow you to explore how these border control measures via a change in imported cases might affect community transmission at the population level. And then last, not an NPI, is vaccination. So from December 2020 onwards, we do have vaccination included in the model, and that is usually modelled from December 2020 onwards in addition to NPIs. This is a figure. I'm going to go through these figures very quickly. The next two figures are the technical background to allow for more time to discuss the second part of the presentation. So we have vaccine effectiveness and waning immunity in the model. These are always modelled at the individual level. We have 4 types of vaccine effectiveness. It's effectiveness against your probability of infection, probability of having clinical symptoms, probability of hospitalisation and death. Because of the way that the model is structured, these are applied as conditional probabilities. So when we're looking at vaccine effectiveness against clinical symptoms, it is clinical symptoms given infection. And then similarly, hospitalization, your probability of hospitalization given clinical symptoms, and so on. So we try to sort of capture that progressively in the model. The vaccine effectiveness will vary by the variant. So in general, there's lower vaccine effectiveness for the more recent variants that have immune escape properties. And the way that we've applied effectiveness and waning, it's just linear, just to make it a bit more simple in the model. And so there's a linear sort of acquisition of immunity after dose 1, and it takes about 14 days to get to maximal protection. Then there's a bit of a wait period while you're getting dose 2. We don't assume there's any sort of waning between dose 1 and dose 2. Then after, once you get dose 2, it takes 7 days to get to your maximal sort of protection provided by dose 2. There's no values here because the vaccine effectiveness against the 4 things that we protect against varies by these 4 factors, but also they vary by variants as well. So there's the multiple sort of values for vaccine effectiveness, but this is all coded and kept track of in the model. After the second dose, there is a time to waning. So right now we're estimating it to be 3 months. So there's like this protective period. It's not truly 100% protective because the vaccine is not 100% effective. So even during this period, you can be infected, but you have very, very low chance of getting infected. And then waning kicks in. So waning after the second dose will kick in, and it will go down. Doesn't always go down to 0, depending on what we're looking at. Waning against infection or clinical symptoms will tend to go down a bit lower. Protection against hospitalization will hold sort of strong for a bit longer because we know there is a sort of better protection against hospitalization, and it doesn't wane as fast. And what we do is also when we boost, we sort of assume that it gets you back to your second dose protection. And then from then on, again, there's another 3-month period before it starts waning again. So very simplistic assumptions on vaccine effectiveness and waning immunity, but this is done for each agent. And also we have protection against protection against infection after acquiring immunity from previous infection. That is assumed to be the same as having protection from a previous infection is assumed to be the same as protection after 2 doses of the vaccine. These are simplistic assumptions that we've put in the model. Very flexible, so we can change them if there is data to suggest that it varies quite a bit, but those are the main assumptions in the model right now. We do have a bit of a model calibration process. Previously, we were modelling and calibrating to clinical cases, reported cases. We no longer have that sort of data to be able to do that. So more recently, we've been switching and calibrating to hospital prevalence. There's a bit of variability, being a stochastic model, obviously, but this is what we sort of use as our benchmark for calibrating the model, so hospital prevalence. I've gone through that really quickly. I wanted to leave some time for the next part and some questions. So there are additional resources available. We've published this model 3 times, and so they're all publicly available with very detailed information on, with more detailed technical background than what I've been able to present right now. So I'm going to move on to the next section, which is what have we modelled to date and what have we learned. So I'm going to start with the first year. I present with the epidemic curve in the background because I like doing this because it kind of shows you why we were modelling what we were modelling at the time that we were modelling it. So I'm going to present every month or sometimes 2-3 months at a time what the theme of the modelling analysis was at the time. So that's going to be presented in black text, and then the red text is going to show sort of like the highlight. What did we learn from this modelling work? So back in February, you know, when it was just, I divide this it up into 4 periods as well. So I call them phases, and it's just based on the variants of or strains at the time in Canada. And so the first, I guess we developed this model in February 2020, and very early on we were just looking at attack rates. You know, what is this virus that that's emerging, and what would it mean? What impact would this have in a completely naive population in Canada? We're just going for the worst case scenario at the time. And the modelling at the time showed, you know, we're estimating R0 for Canada to be about 2.5, and approximately 65 to 70% of Canadians will be infected without intervention. So this was quite concerning at the time. And over the next few months, we moved into, you know, given this, and we didn't have a vaccine at the time, all we had at the time, the only tools that we had were non-pharmaceutical interventions. And so we looked at focusing on the NPIs that were available at the time to help flatten the curve. We looked at sort of combining these NPIs, and these were generally contact tracing, case detection, physical distancing, and closures. So these are the sort of NPIs that I had gone through previously in my previous slide. We looked at enhancing these NPIs. We looked at sort of, you know, when can we even lift NPIs after the last case reported? This makes me smile sometimes because I feel like we were so hopeful at the time. Back in April, we thought that we could start thinking about lifting. But, you know, I guess now we know that was not to be the case, but it was interesting to sort of model that. We also went through a multi-model approach. So as mentioned, the ABM that I'm presenting is not the only model that we use within the agency to use for guidance. And so we looked at sort of comparing with other models, like and sort of our approaches to combining NPIs. And then we looked at the impact of household co-isolations. When I should mention, when we talk about the effectiveness, or when I talk about the effectiveness of MPIs, it was always evaluated on the ability to be able to prevent the healthcare capacity from being overwhelmed. So primarily our hospital beds and ICU beds. This was and still remains as the primary objective of implementing public health measures. And so when I talk about exploring the effectiveness of NPIs, this is what it's talking about. We evaluate effectiveness in terms of it being able to keep hospital beds from being above the threshold of the number of beds that we have available for COVID patients. So what we found were all NPIs were effective. Some are more effective than others. For example, we found physical distancing to be very, very effective, and closures. But the best was when they were all just combined together. So what we found early on was you can't drop any of these. Like, you really have to use everything you have, especially at the time when you don't have vaccines. You use everything that is available to be able to control this pandemic, given that we know it's going to affect possibly 65 to 70% of the population at the time when it was wild type. So now it's probably going to be different. So over the next few months, we looked at sort of more strategic MPIs. So what if we targeted certain industries? And so we looked at sort of staggering school starts and cohorting in preparation for the return to school in September. Then we looked at return to work strategy. So, you know, you can see with that epidemic curve in the background, like it was a lull period. Things were really hopeful. We were going to possibly sort of get our lives back on track. People were going to return to school. We'd send our kids back to, we'll send our kids back to school. People would return to work. And so what we modeled really mimics what was happening at that time, at that point in time during the pandemic. And what we found were targeted MPIs were effective at reducing transmission at the intended population, but there was additional benefit elsewhere. So for example, if you prevented school transmissions, you could actually prevent transmissions in the household. You would be able to prevent, if you prevented transmission in the workplace, you would prevent transmission in the community overall. So this was really, and we could quantify. So, I mean, these are obviously concepts that logically make sense, but to be able to quantify it was really neat, and the models were able to show that. In August, we were looking at the impact of imported cases, planning for border reopening, because things were still looking pretty good. And so, you know, we looked at sort of lifting up some of these border control measures and what imported cases would, an increase in imported cases would do to community transmission. What we found were public health measures, particularly physical distancing. If we could maintain that, we could really reopen and have that additional imported cases come into the population without really causing a spike in cases in the community. Then the next few months, we focused on, unfortunately, at that time, we were heading into our second wave. So really looking at, okay, re-implementing shutdowns. And how do we do it effectively? So, you know, can we modify the speed at which we shut down, how long we shut down, how long we wait between shutdowns, and sort of closing different industries down. So could we keep schools open but close down non-essential businesses only? Could we keep people teleworking and open schools? Lots of different combinations. And what we found was shutdowns were highly effective, but they were not all equal. And there isn't really a one-size-fits-all optimal way. So it really depended on sort of the goal of shutting down and who you wanted to prevent disruption, or which group you wanted to prevent disruption to. I guess the next few months were phase 2 of the pandemic in terms of alpha variant introduced into the population. We were focusing more on sort of vaccines at the time as well, because in the same month that alpha emerged in Canada, vaccines became available to Canadians, which is great. But it was also not great that we had alpha variant. And so we were modeling the two of these. We went back at some of the previous analysis and now remodeled the MPIs that we needed, despite having vaccines available. You know, could we, I guess, lift some of these MPIs? And what we found was that no, we had to keep some of these MPIs in place while Canadians were getting their vaccines and slowly building up their immunity towards COVID. This is the second year. So second year for us is February 2021. Now we were focusing more on sort of vaccine effectiveness. We had a bit more information about that. Also, at the time, there were delays in vaccine supplies. So we were sort of faced with the decision of, you know, a delayed dose interval of 28 days between dose 1 and dose 2 and 4 months. And so we did a bit of exploring on that. And we also spent a bit of time looking at vaccination coverage needed in order to lift those MPIs. At this stage, we still had those MPIs in place and they're quite disruptive. And so, you know, at what point in time, or at what vaccination target can we aim for in order to lift? And our models showed that approximately 75% of Canadians 18 plus needed to be vaccinated in order for us to start lifting those MPIs. We also had some interesting sort of, depending on vaccine effectiveness against infection, you know, whether the 4-month interval or 28-month interval was better. Ultimately, we ended up getting more supplies and we ended up giving people an interval of 8 weeks. So, but that's what we spent our time working on during those months. The next couple of months, we looked at, you know, vaccinating a larger group of people because the vaccine became available to adolescents at the time. There was vaccine hesitancy, so we modeled that. We updated our vaccine coverage, and so we found that 75% of the eligible population, 12 plus, needed to receive their vaccine first dose and 20% with their second dose in order for those MPIs to finally be able to lift. That was kind of good news and positive news, and we were heading into the summer, things were getting better, so that was kind of nice. And a nice motivation for Canadians to go and sort of get vaccinated. Then Delta variant came. And so we had to actually go back and revise our modelling to incorporate the introduction of Delta into the population. We then also had to revise our vaccination target and also look at border reopening, because our previous border reopening was prior to Alpha, and so things change with each variant. And so what we found was targeted vaccines needed to be applied to 80% of the eligible population 12 plus, with enhanced testing and contact tracing to accommodate for reopening and an immune escape variant. We continued the next month to sort of include children in the vaccine acceptance, in vaccination targets, and that obviously helped. And then I guess unfortunately with the Delta resurgence, we had to look at reintroducing NPIs and modelling. Now this time around we had a new tool, which was a vaccine mandate, and we found that it was extremely effective and a good alternative to shutting down. So during the Delta variant, we really didn't shut down. We had the vaccine mandate help us avoid those shutdowns. Then we finally were able to vaccinate children, and then there were boosters available as well. So we incorporated that over the next couple of months and found obviously the more you vaccinated and boosting people were very helpful in keeping control of the epidemic. And then Omicron emerged, and the focus over the last few months has been expediting and increasing booster uptake. And what we found was, despite Omicron being less virulent than the other variants, modelling showed without increasing boosters or re-implementing strict public health measures, we would overwhelm our hospital healthcare system, unfortunately. I don't have any other bullet points, but we obviously haven't stopped working. The modelling is continuing, but I hope I've been able to convince you and say that we've learned quite a bit over the last 2 years, thanks to modelling, not just the ABM, but for the group of models that we have within the agency. A lot of the work, everything that I've mentioned is publicly available, so I urge you to go to these sources and please feel free to take a look at your own time. So I'm going to address the last topic or question, was it worth it? So I realized what a can of worms I opened up when I gave Ali this title, and it's quite a philosophical question. So I don't know if I am able to answer this question properly, but I started thinking, well, at the individual level, you know, I had one working ABM when there was no technical glitches, but it was like about 5,000 hours of my time, sleepless nights, time away from my family, lots of tears. Maybe it's not worth it at the individual level, but then it becomes balanced when I looked at it from a team's perspective. Well, there's about 40 people on my team. We all didn't sleep very well, lots of tears, but we were able to, as a team, provide guidance on the effectiveness of MPIs, timing of lifting of MPIs, these sort of gradual sort of updated vaccination targets, and all of this in the goal to help prevent strain on the healthcare system. And I think, well, maybe that makes it worth it. So how about from a public health perspective? I thought we did actually coincidentally conduct a counterfactual analysis to quantify this. And so what I did last week was actually look at the public health measures that we had in place, all the MPIs that I've talked about, vaccinations, and then we looked at, I guess, what if we took those away? What if we didn't have vaccination? And we ran the models to see counterfactually what would have happened. What if we didn't have the public health measures in place, but we had vaccines in place, you know? And then we also kept the non-pharmaceutical interventions in place after, and then lifted after the first wave, then after the second wave, after the third wave, after the fourth wave. And then we looked at the infections prevented, the hospitalizations and deaths averted, and whether it prevented strain on the healthcare system. And this was like a neat way to quantify sort of what like the worth of all the effort that we've put in over the last 2 years. And so just briefly, this is what we found. Vaccination and NPIs in Canada have prevented millions of additional infections and tens of thousands of hospitalizations and deaths. The NPIs in Canada have been slightly more effective than vaccination, but the combination of the two has helped in combination reduce the morbidity and mortality considerably. Each additional shutdown prevented additional infections, hospitalizations, and deaths. But the earlier shutdown prevented more, but this was only because we didn't have vaccines available at the time, and we had a completely naive population. So over time, as people became infected, those sort of NPIs were less effective only because people were protected from their infections over time. But infections, hospitalizations, and deaths prevented are not the only metrics to measure worth. And so, you know, obviously there are socioeconomic factors, disruption to society, quality of life, and that is not something that I have the answer to, but perhaps the next ABM for Public Health theme for York University to consider. So, key messages. Modelling has been key to developing federal guidance for COVID-19 public health response in Canada since February 2020. The ABM is one of multiple models that we've used in a multi-model approach to provide guidance. The use of ABM at FAC is a really good example of agent-based modelling for public health. Hopefully I've been able to convey that message across during this talk. Much has been learned over the last 2 years from modelling, and we continue to learn more as new variants emerge. Is it worth it? Well, I think it really depends on who's being asked. So from a public health perspective, in terms of preventing strain on the healthcare system and severe outcomes averted, I would say the answer is yes. I'll leave others to debate whether it was worth it otherwise. And finally, I want to leave some room for questions and obviously acknowledgements as well. Thank you for attending. My family, who have spent a lot of time away from me or who I've kind of neglected throughout this work. And of course, my Public Health Risk Sciences Division family at the agency, in particular, Dr. Kelsey Spence and Dr. Vanessa Gabrielle Rivere, who are my sort of co-modelers and helped a lot with this work. So I leave with the graphic that my daughter had drawn up when she was 7. She's now 9, so this is pre-vaccination, but she posed some wise words of wisdom at the time when we were all thinking about lifting. So I end my presentation and I welcome any questions that you have. Thank you.
Thank you very much, Victoria, for very, very interesting talk and covering the whole 2 years of hard work and of course rewarding achievements. We have a good number of questions actually on the crowd, but I see John Hung was about to say something. Please go ahead. And in terms of responding to questions, whether I'll leave it to you whether you want us to read the questions one by one, or we invite people who ask questions to come and ask verbally, or you want to read the question from the Q&A part and respond to them. Whichever you prefer, we'll leave it to you. Jian Hong, if you have any comment. Yeah. Yes, Phyllis.
Yeah, I just want to make comments first of all to answer your question, Dr. Ying. You asked if it's worth of it. I just want to tell you it's absolutely it's worth of it, knowing what the efforts that your groups, the multiple groups within PHAC have been working, and knowing how the decision is really rely on those projections and assessment. I think is absolutely worth of it, and I think especially in terms of your family, they will, the younger generation will definitely will be proud of what you have been dedicated over the last 2 years. I have a question for you, and knowing that you have multiple platforms within the PHAC modeling team, and how you cross-validate each other, and know the agent-based simulation is one of the backbone platform down there.
Yeah, so I mean, there isn't a uniform way to cross-validate. We do come together, so we're usually modeling the same thing at the same time, and we do come together and say, this is what I modeled this week. Are you seeing the same results? So it's kind of like very, it's not, you know, there isn't a structured way to compare, but we also understand that we have structurally very different models as well. And even sometimes our inputs are different. And so we wouldn't expect it to be exactly the same. There are certain things that some models can do that others can't as well. And so sometimes there's no comparison. But in general, we do have weekly meetings, and it's really just very ad hoc, trying to sort of be on the same page as each other and making sure that what we're modeling for that point in time of the epidemic is consistent and that our messages are consistent. And I will say that despite that, the fact that we have very different models across the agency, we've always been very consistent in terms of, you know, what the projections are or what our scenario-based modelings are showing us. So how effective certain NPIs are, how effective letting go of NPIs would be, or sort of not how effective, but how bad it would be if we let go of some of these NPIs. And so even though the models are structurally very different from each other, the messaging was always the same, and that was sort of brought together by you know, the director of our division to then sort of relay to senior managers. But I mean, it obviously helps when the models are producing results that are sending the same message, and then these will usually be captured in presentations to the CPHO and the Minister of Health. So hopefully that addresses your question.
Oh, yes, thank you, Dr.
Yeah, and Alice asked me, I mean, there are a lot of questions. I feel like maybe we should go, I will go through the Q&A and answer those questions first, because those people took the time to pose those questions. And then if there's more time, I can answer them in verbally. I've got the 6 open questions. So it does not run through an event queue from event to event. Martin, no, it does not. And that's not to say that it shouldn't do that. It's just the way that we developed the model. We did not do that. How are the contacts amongst agents happening? Okay, so we do have the contact matrices between the different locations, and every day we reset contacts. And so if you're an agent who is infected and you have to look for contacts to infect, every day you get reset. We look at where you are going to that day. We divide those contacts amongst families and the locations that you're going to, and we send those contacts to those locations. And then who receives them will depend on the age group. So depending on how old you are, the receiving person who gets that contact is going to be around the same age as you most of the time, but we do allow for some random contacts to happen as well. Also, how did your model state transition? Did you treat them as being memoryless, Markov, or did you do some sort of control that included time? It was conditional probability distributions, and it included times. So that was a quick question to respond. Feel free to also contact me. If you look up the publications, my contact information is available. So if I don't address your questions properly, you're more than welcome to contact me to clarify. How did you go about determining the relationships displaying on the contacts slide? Determining a relationship. Okay, so it was really age-based relationships. That's what we have in the model, and that's how the contacts are in the contact matrices. And so it was determined by age group. But as I mentioned, like, we do allow the probability of random contacts in other age groups as well, because they do happen, and especially in workplaces, right? So, you know, you do tend to work with people around the same age, but there are other people in other age groups. So when agents were looking to infect people in the workplaces, they were able to assign contacts to a larger age group. But if you were an agent going to school, you were more likely to infect someone around the same age. So the contact matrices sort of was coded as like a probability distribution by age group of who you were going to distribute your contacts to, or who you were going to give your contacts to for a particular day. And you had to retain some contact for your family members as well, because you go back home and you have to infect your family members as well. And so it resets every day. Those contacts are resetting again, because locations, people are going to different locations on different days as well. It varies by weekdays and weekends. And so every single day it resets. There's no sort of day that's the same as each other. Fourth question, what about workplaces and school-based MPIs? Yes, so we did have, we do tests, you can actually implement some of the MPIs that I mentioned specifically for locations. So we did, during a couple of months, look at workplace and just testing in the workplace and how that might affect the population. We also looked at additional testing for the whole community and how that affected everyone, and then schools as well. So the model was very flexible. You could impose those MPIs to anyone in the model or any location. Can you compare the effectiveness of the ABM models versus other modeling approaches? I think that's a really subjective question. It depends on your definition of effectiveness. I don't, without knowing that, Philip, I don't know if you're still there. Maybe you can sort of pipe up and explain to me what you mean by effectiveness.
I think he is. Go ahead, Philip, if you want to. Probably not hearing us.
No? Okay. Yeah, I guess.
Can you hear me?
Yes,
Yes.
we can. Go ahead.
Yes.
So what I mean is, which one, if you were to only use one approach, which approach would you use? Would you use the agent modeling? Would you use the SCAR model, or
So I would say it depends. There is not one model that's the perfect model. And if you have time and the resources, I think you would want to actually use a group of models, which is what we're doing within the agency. You don't want to put all your eggs in one basket and just rely on one model. The more models you have, the more you can compare, and you can you can if there's one model out of three, and one is going a different direction, you can then challenge it a bit more and say, why did it do that, right? If you only have one, you don't have that luxury to be able to know, is this telling me something that looks like it's right or not right? But I mean, it really depends as well. If you have a lot of time, I mean, yeah, do a really complex dynamic model, and then you can capture everything. The advantage of an ABM is that you can sort of capture a lot of these different sort of factors when we're thinking about something as complex as infectious disease modeling. But the drawback is it takes a lot of time to run and to analyze. And so, it's always a bit of a trade-off. So I guess I wouldn't be able to pick one model over another. I think you want to be using everything that you have. But, it depends on your question as well. If you need to answer a very simple question, maybe you don't need an agent-based model to answer that. And I think, we went with the all models approach at the agency because we didn't know at the time what we had to answer. And you definitely just want to make sure you're prepared to answer all the questions that you're going to be asked. So hopefully that.
Were you asked for confidence intervals on the results?
Oh, absolutely, yes. Well, for the agent-based model, I mean, some models, you're always going to get the same results. They're not stochastic, so you can't do that. But yes, for the agent-based model, that's one of the advantages for a stochastic model, is that you can provide some sort of certainty around the uncertainty of outcomes. And certainly, we explored, like at minimum, we always presented on 50 model runs. It always showed you that one or two odd outlier that, if it can be modeled that way, it is a possibility. But if it only comes out 2 out of 50 times, then you have more confidence that the projections are going to go the other way.
Victoria, I don't know about your timing, but if you have time, I think there are a couple of questions, or there's one question in the chat. I have one question also, but I can defer it to later on.
No, you know what? I'm not in a rush, so
all right.
please go ahead.
So
yeah.
for those who are with us, probably feel free to stay or leave if your time doesn't allow. We continue with some of the remaining questions. One question is from Kurt in the chat, actually. And if you want to read it yourself, it is from Kurt.
Sure. Yeah, I'll just be brief. There were two questions.
Kurt is here. Go ahead.
Yeah, thanks. Oh, sorry. I thought you were directing me. The first question was just a brief. You were talking about sort of is the whole thing worth it, and you were doing that. How many deaths and so on averted. I'm just wondering if you included in that any deaths that would have been caused by hospital overruns.
So it's captured. That is captured in the model.
Yeah.
So I don't separate it. But in the model, we assume when the hospitals are overrun, that the death rate is increased because of that. And we do parameterize it, but we based on, actually, we have data from Italy. Thankfully, that didn't happen in Canada, right? Thank goodness. And so it also means we don't have data on how to parameterize that. So we looked at what was happening in Italy at the time, because they certainly had that problem at the beginning of the pandemic, and we used that to benchmark, how we would to increase the mortality rate if there were no hospital beds available for patients.
Yeah, thank you.
And so that is captured in the excess. In the counterfactual modelling work, I did not separate it out, but it could be pulled out from the model. But yes, yeah, it's a really interesting point. It's a sad point, but definitely something that we did try to capture.
Thank you. And then the other question I had there was just an invitation if you wanted to talk a little bit about how the modeling was communicated to decision makers, and how, as a modeler myself, it's often difficult to take a model run, and sometimes decision makers want sort of a prediction or a nice plot that says this is how many people are going to be there and this is how many people won't be there if you do this thing. And we as modelers recognize that the insights from simulation models are not always that precise. Almost they're never that precise. So I'm just wondering if you had any insights on how that communication with decision makers went, and how they were able to take that sort of complex set of model runs and distinctions into sort of informing policy.
Yeah, absolutely. So we definitely did run a lot of these models and answered a lot of questions that were being asked of us from senior managers. And I guess that's one of the sort of nice thing about being a government scientist, is that the work that you're doing, it's not just work, right? It's applied to the situation at the time. And so we would be asked a lot of the times, like, what is our vaccination target, for example? That was always like one of the sort of early questions after we received the vaccine in Canada. What do we need to target, given what we're facing right now, given our assumptions on how many people have been infected previously? Like, what is the vaccination target that we give people as a target publicly to encourage them to go vaccinate? And this is a really good example, because that was what we were being asked. And so through the modelling work, and not just the ABM, but all the other models that we have within our team, that was how we came to that 75% at first dose and 20% at second dose. I don't know if you remember at the time, like that was sort of put out there first through the CPHO presentations, and then it was picked up by the media, and then a lot of the provinces and territories use that as their vaccination target. Now, obviously, I can't speak for the provinces and territories. They may have internal modelers as well that came to that same conclusion and the same vaccination target. But we always use our modelling work to advise sort of federal guidance, and so that was the target that most of our modelling work, like we were working on this, we were refining and fine-tuning the models, came to that target, and we were pretty confident at that point in time that it was quite accurate. We were still a few months ahead of that target, but it seemed like a really good target to put out publicly. There is a group of advisors and managers within FAC that discuss these issues, and how to sort of present it in a way to the public that is transparent, that is easy to understand as well. You know, they don't need to know the ins and outs of, you know, the technical details of the models. They just need to know simply, what do I need to do to, you know, end this pandemic and keep myself safe? And so there is that process within the agency, and it starts off with the modelling, which is really neat. You know, I feel like modelling within the agency has really been recognised as a strength and something that we look towards to try to help make decisions or provide guidance for decision making. And so the models were in fact being asked to answer these questions, like, when do we lift? Should we be lifting? Can we change our border public health measures and allow more people coming in? Are we able to handle that, you know, given the state of the pandemic that we're in Canada? So these were all very real questions that we get asked. We model, it goes through sort of a process to sort of make sure that the messaging is clear. There's cross-validation between the models, between different models and my colleagues. And we all make sure that, you know, we're confident with the results and that they're all showing very similar results before it gets to the point where we do share it publicly and it becomes disseminated and becomes sort of official guidance, I guess. So yeah, it is, but it starts off with modeling, which is kind of, and questions. Well, I should say that's how it starts off. There are questions, and then you adapt your models to address those questions, and then it just goes back up like that. So I hope that answers your question, Kurt.
Yes, thank you so much. That was wonderful. Wonderful, thank you.
You're welcome.
Thank you very much. Well, I have a quick question, and hopefully we finished the meeting with that. And that was, I know that you posted the model and make it public, but are you going to publish the latest version of the model that you have, or new versions of this as we go? It is one question. The other question is, I found it really interesting and possible to make this model sort of provincial based, so that we divide the population that you have based on provinces, or adding a geographic element to it, making it a geographic agent based model. Have you had a chance to or explore this as a future possibility and direction or not? That's my question.
Yeah, thank you. So we have actually shared this model. So with all the publications, we include a link to where you can download the model file. So you're right, though, that link, it doesn't contain the most updated model, only because the model's just been updated so much. But there is a contact person that you can ask, and we have shared the model like countless times with provinces, territories, other collaborators, and we've shared the model file for people to use. So certainly we're very interested in getting the work out there and making it publicly available. We have actually shared it with some smaller provinces and territories, and they have then tried to adapt it for their own provinces and territories. As you say, you know, we're modeling at the national level. That's our sort of, you know, our mandate and our priority at the federal government. But things vary by provinces and territories and regions as well. And so the model is flexible enough that if you modify the parameters so that they're more reflective of your population of interest, then you could adjust it and model more sort of regional, like region-specific outputs. For example, like for a while we were helping, I think, like model in the Northern Territories, where the community, the household members, like, you know, they live in far larger numbers than we do nationally. And so if you can change that, you can change your contact matrices. So there's a spreadsheet, so you can update that spreadsheet on the probability of distribution based on the region of interest. So you could do that. I mean, I say easily though, but it is like 100 parameters. So you would have to think about, well, what is consistent? Like maybe vaccine effectiveness is consistent. You wouldn't expect that to change across regions. But there are certainly some parameters that are like contacts and household numbers that would be very regionally specific. Nothing would stop us from converting the model into a more regionally specific model. The only thing is time. And so, yeah, if we had time and people, any graduating students who are interested in working in this field, you know, certainly there's so much possibility to sort of make the model more refined.
Absolutely. Yeah, I really like that. We tried adapting this to a smaller community, and it works really well. And it is a GIS-based, yes, and it is a GIS-based version of it. But the one that we worked with was not the latest version that includes, you know, vaccination and other things. But it's really possible, and I'm looking forward to turn this actually to a provincial, you know, level GIS-based model too, if that is of interest. And so with that, I really want to thank you for your time and for your work and your team for doing this. This was certainly one of the very robust agent-based modeling effort during a pandemic, and we just don't know how to appreciate, you know, all you did. And I think it is contributing a lot for future modeling and for you know, modeling of using agent-based modeling in particular. Thank you so much. Jianhong, you want to find? All right, thank you so much. With that, we conclude this session, and thank you everybody for participating. Looking forward to our next session in 2 weeks' time with another exciting presentation. Thank you all. And thank you, Jane, for hosting this. I just want to mention to Victoria that Jane was actually teaching in this period. So she kindly accepted to make the introduction and go to her class in between. So that was the reason she was not taking the question. Thank you so much.
Thank you so much. Bye.
Thank you all. Bye-bye.